Now we'll talk about spinal injury. Number one cause of spinal injury, trauma. Clinical manifestations of spinal injury, spinal cord injury would include pain, numbness, inability for the patient to move or walk. They may not even feel pressure, heat, or cold, so painful stimuli would definitely be a no. They may experience muscle spasms, loss of bladder or bowel. They may have difficulty breathing depending on where the injury is, and cardiac dysrhythmias, again, depending on where the injury is. Assessment data, as with TBIs, you assess ABCs, that's your priority in any sort of trauma situation. Assess for intra-abdominal hemorrhage. You want to do a Glasgow Coma Scale. Assess for any signs or symptoms pertaining to neurogenic shock, which is also called spinal shock, which you'll learn about next unit. So you'll be assessing for bradycardia, decreased or absent bowel sounds, warm skin, dry skin, hypothermia, hypotension. Autonomic dysreflexia is a potentially life-threatening thing that can happen to spinal cord injury patients. Usually seen in patients with an injury above T6. Acute onset, so it can happen very quickly. And like I said, it's life-threatening. So neurohormonal release of norepinephrine and dopamine, which causes severe hypertension, headache, blurred vision, bradycardia, flushing, nasal congestion. When you see it, you'll know it's autonomic dysreflexia. A way to treat autonomic dysreflexia: removal of whatever the stimuli is that's honestly messing with the patient's system. So if you have a patient that's quadriplegic and they're trached and vented, you obviously can't have them sit upright. So you'll have to roll them back and forth, smooth out the wrinkles underneath them. Maybe their gown is too tight, so you want to remove the gown, loosen the gown. Be sure to monitor the blood pressure very closely. Catheter these people to empty their bladder, because that could actually be a cause. And you may actually end up administering medications such as nitro to control the hypertension. For nursing interventions, treatment, you need to know what autonomic dysreflexia is before you can actually treat it. Do those things that I just talked about. Patient education, bowel or bladder schedule for your patients that are maybe paraplegics, and so they're living independently in the home, but they do need to be on some sort of calendar or schedule for bowel and bladder regulation. Skin management, again, for those patients that are more independent in the home, and prevent reoccurrence.